are here live with Dr. McIntyre from the 2022 NEI Synapse, and we are in Austin, Texas, and he just finished his presentation on bipolar disorder. Welcome, Dr. McIntyre.
Sabrina, great to be with you and wonderful to be in Austin for Synapse. Great to see colleagues and both virtually and also here live at the Austin Center here at our program.
Yes, we're so excited to be here. And I'm very excited to give people a chance to get their questions answered. We like to do this at our live events to allow people who may have submitted questions during your presentation a chance to have those questions answered. So without further ado, the first question for you is, do you consider the adverse childhood experience in your evaluation and comorbidities?
I really do. And I want to first of all thank our colleague who submitted the question. I do think evaluating for adverse childhood experiences should be part of each and every assessment of a patient for no other reason than it's obviously a very meaningful event to the person we're working with. That alone is, for me, is the call to action. But it also has the additional part to it, and that is we know that if you have adverse childhood experiences like neglect or abuse, physical or sexual abuse, that increases the likelihood that the treatment that you're going to receive for bipolar disorder may not be as reliably effective. So therefore, I'm going to need to make a very close determination as to treatment helping you or not, watching my patient very carefully. The other part is, of three, is that it contributes to comorbidities, not only drug and alcohol misuse, but also, in fact, other comorbidities, which are not exclusive here, but obesity and diabetes and heart disease, something which we've also been able to show in some of our data. So this is another reason to consider. And then finally, when I'm designing the care plan, a lot of patients who've had trauma might have other aspects of complex PTSD phenomenon that might require psychotherapy. So the care plan might include psychotherapy to really target that phenomenon. So it has not just an academic aspect to it, but a very meaningful clinical reality and translation why this information is so critical.
Thank you. That was an excellent answer. Is the early onset of heart disease or metabolic syndrome in bipolar disorder related to chronic inflammation from familial predisposition and possibly trauma history?
Yes, and what a great question. And both are likely contributory. In other words, we are still in our infancy with respect to understanding the genetics that subserves bipolarity and its comorbidity like metabolic syndrome. But what's there, which is interesting, is suggesting that genetic variation in the area of the genome responsible for inflammation may be a risk factor for bipolar and its comorbidity. So it definitely has genetic architectural elements to it. And the other part is, yes, their history, like trauma is a stressor. In trauma, when it's transduced as stressor, in other words, the body experiences trauma as a threat, and threat is reacted to with pro-inflammation. And what we've discovered at my center in Toronto is that when you have a history of bipolar disorder and trauma, you're much more likely to exhibit inflammation. What's interesting, Sabrina, is we did a study a few years ago in bipolar depression, and we found that anti-inflammatory treatments to treat their depression sort of worked, sort of didn't. But when we only looked at the group of people with trauma, the anti-inflammatory treatment for the depression really worked. So if you want to know if your patient is, in quotes, inflamed, yes, you could do a CRP analysis, but you could just ask them, are you traumatized? That could be a strong indicator that they have inflammation activated, and that may be leading to the obesity and the diabetes and heart disease, as well as some of the other aspects about their brain health that we discussed at Synapse.
Mm-hmm. Mm-hmm. Wow, that is fascinating.
Really is. It's really interesting indeed.
The next question is, this person says, I'm aware of data supporting use of L-methylfolate in major depressive disorder in those who are obese, but is there data to do the same in bipolar disorder?
Our colleague is so correct. There's really interesting data that if a person has depression and they are obese and or they have elevated inflammatory markers, they're more likely to benefit from L-methylfolate, which is in keeping with the hypothesis that L-methylfolate may have some direct or indirect beneficial effects on the inflammatory system, part of an inflammatory biophenotype of depression. Admittedly, in bipolar disorder, we don't have the same level, quantity, and quality of data for L-methylfolate. We have some data, but we don't have a lot. But in keeping with the view that there are subpopulations of people with bipolar who are more likely to benefit from an intervention that is, in quotes, anti-inflammatory or having effects on metabolic systems, we have some really interesting data that metformin can now improve not only insulin sensitivity in bipolar, but can improve depression in those with bipolar whose insulin sensitivity improved. And as well, to a comment earlier, anti-inflammatory treatments in bipolar may be more likely to work in people who have obesity and or trauma or some other indicator of pro-inflammation.
Wow.
So interesting indeed, right?
Yeah, absolutely. This next question says, do you think that if we implement ACEs screening in every new patient we see, that it could also guide us in the direction of suspicion of certain diagnoses in treating patients? It is not standard practice in general from what I have seen.
Yeah, great question. I think that the short answer would be, I think that we should consider something like the ACEs, just so we're all on the same page, Sabrina. This is like an instrument for evaluating adverse childhood experiences. I'm also a busy clinician myself, and I know people are busy, and the last thing they need is more scales and instruments. But I'm also aware of the fact that I think at the very least, have it in your EMR when you're doing your consultation to ask every patient about trauma and get into some of the aspects around that. If you are able to supplement that with something like a systematic screener like the ACEs, I think that'd be even value add. But at the very least, I think there should be at least, a line of questioning around this, because to our point earlier, a history of trauma does have implications for how bipolar disorder presents, the trajectory, the prognosis, the response to treatment, comorbidity, and also the person's human experience in living with the illness and living with their life. And this is obviously something we want to know. It could shape the care plan vis-a-vis, it might invite the need for us to include a treatment more for complex PTSD or other aspects to help patients navigate the internal experience of trauma and bipolar disorder.
Wow.
Yeah.
Regarding cognitive dysfunction associated with bipolar disorder, is there a role for the central alpha agonists?
Wow, great question. I would say to be determined. That's my answer. My answer is 3 letters, TBD, to be determined. It's a great question because cognition impairment affects about 2/3 to 3/4 of patients. I always talk about, Sabrina, the 1/3 rule. So 1/3 of people have a deficit in at least one domain of cognition. Another 1/3 have a deficit in multiple domains, and about another 1/3 seem to have no apparent objective cognitive deficit. So 2/3 have got some problems cognitively, and we don't have a treatment, but modulating catecholamine systems is an interesting proposition. So far, there's no data in that area, but we've looked at various ways, whether it be giving people stimulants, even people looked at modafinil, and armodafinil has been looked at. There's been an attempt to look at pramipexole. There's many others, of course, but for now, I would say stay tuned. For now, alpha agonist would be considered. It might be some other type of manipulation of the catecholamine system, but for now, there's many options on the table being evaluated.
Excellent. The next question is, what are explanations other than bipolar disorder that we should look at for lack of response to antidepressants?
Yeah, this is a really important question that not only is relevant clinically, but has such profound scientific implications. I think we need to just remind ourselves that the antidepressants were developed after it was discovered that when you deplete monoamines like serotonin, that could induce a depression-like syndrome. And I think that the glass is kind of half empty, glass is half full. The half full is that many people do extremely well with antidepressants based on what was really a serendipitous discovery, a discovery by accident that these drugs could possibly work. But for most people, antidepressants don't really help them get their lives back. And that's just the reality. And that doesn't mean that antidepressants don't work any more than penicillin doesn't treat all pneumonia. What we need to do is better understand different subtypes of mood disorders. And it would be the case, just like infectious pneumonia, that there's different types of depression. So we're going to have, for example, Sabrina, some depressions that are responding to antidepressants of the conventional variety, but maybe other depressions we need to target glutamate. Maybe others we target GABA. Others we target the orexin system. Maybe it's the inflammatory system, then the metabolic system. So we've kind of seduced ourselves into kind of overly simplifying depression, that all depression's the same and they should all benefit. And if they don't benefit, it means that our antidepressants are just no good. That's not the conclusion. The conclusion is that penicillin works for some bugs, but not for many. And our antidepressants work for some types of depression, but I would never expect them to work for all types. And I think that's for us how we should translate what's happening in terms of clinical research. Now, in bipolar disorder, a bit more complicated because bipolar disorder is not depression with mania. It's a different organism altogether. And for reasons we just haven't fully sussed out, that antidepressants just don't deliver. I would offer the hypothesis that this is because this is a different organism. And that's why we're not seeing depression get better. So the depression of bipolar is not the same thing as depression and unipolar illness.
Mm-hmm, mm-hmm. Wow, such a great answer. How much do you consider FDA indications when choosing an agent for bipolar depression? For example, do you tend not to prescribe lithium and lamictal for acute bipolar depression due to lack of indication?
What a wonderful question. And I think this is so critical to how we as care providers support the decisions that we make. So decision support, I think, Sabrina, should be guided by, frankly, 4 different elements. First, what's FDA approved? Second, what's recommended in treatment guidelines or so-called clinical practice guidelines, CPGs? Third, what is the scientific evidence support? And fourthly, what's your clinical experience? Now, in an ideal world, everything's in harmony, but the reality is, and I mentioned this during the symposium today, our session, I vacated the ideal world. I don't live in that world. So some drugs have been shown to be effective, but are not yet FDA approved because they haven't gone through that process, et cetera, et cetera. Some drugs that are FDA approved have side effects that for me are kind of deal breakers for my patients. And I won't give them first line. I think about quetiapine and bipolar depression, all the weight gain. So I think for me, I take all 4 of those sources of decision support into consideration. I do, in fact, give priority to what is FDA approved and what is the evidence support. And in bipolar depression, we have several treatments like cariprazine, lurasidone, and now lumateperone, FDA approved, evidence-based, showing to be effective and not burdening patients with lots of side effects. Lumateperone is efficacy in bipolar 2 disorder. You've got cariprazine efficacy in mania mix. So you've got scenarios here. So I think we have to do that. But here's the bottom line, Sabrina. We know that most people with bipolar are receiving treatments that are not FDA approved, not evidence-based, not in keeping with guidelines. And so that's a gap we have to close. We call that the implementation gap. We got to close that. And so I think all 4 sources of information instruct and provide information for us.
Wow, I think that's so helpful. This next question asks, is there any concern for transcranial magnetic stimulation induced mania when treating bipolar depression?
Yeah, wonderful question. I do think that there is the risk, not just with TMS, but also with ECT for possible induction of hypomania or mania. Now, the evidence suggests that's not a very common phenomenon. And by the way, just to put a fine point on this, one of the aspects we always need to consider when trying to interpret this observation is it that TMS or ECT, did it actually induce mania, or is it the case that the mania was going to happen anyways and the ECT or TMS just failed to prevent it? Those aren't mutually exclusive, but that needs to be considered because about a third of people, Sabrina, become hypomanic or manic after depression, no matter what you do. So it could be part of the naturalistic switch. Taken together, is it reported? Absolutely. But what would I do? I would probably end up treating them with an antipsychotic if they had mania. But I would say that it's not a very common event, all things created equal. By the way, with ECT, Sabrina, if they have mania coinciding with ECT for depression and bipolar illness, what's the next step? Give them more ECT because ECT treats mania too. So that's something that's a little bit different. So anyhow, yes is the answer. And going back to the point about lithium and lamotrigine, I would consider that treatment only after an FDA-approved treatment, like the ones I mentioned in bipolar depression, lurasidone, criprazine, lumateperone. But I want to make a fine point on this. TMS and ECT are on the list, but not until after I've tried some of the evidence-based treatments. And I'd probably use lithium and lamotrigine before I would use TMS or ECT in most cases. And I use lithium and lamotrigine after I've tried one of the 3 atypicals that I've described earlier. No, I had not mentioned quetiapine. Use it sometimes. I don't use it a lot because of weight gain and metabolic problems.
Right. Okay. This next question is, does Lamictal affect memory in the long term?
Wonderful question, because we know that anticonvulsant drugs, there's many of them out there, over the years have been pretty consistent at resulting in cognitive impairment. And clinicians see this with divalproex, carbamazepine. You see this with phenytoin. I mean, there's so many. Lamotrigine seems to be an exception. Let's start off with do no harm. Lamotrigine does not appear to adversely affect subjective or objective measures of cognitive function, at least as best as we can ascertain in bipolar disorder. There is a suggestion, and only a suggestion, that there might be some benefits in aspects of cognition, but I want to make it very clear that's not been proven and that's not well established. But there's actually some suggestion that it might help that in some patients. But taken together, I'm going to arrive at the conclusion today, lamotrigine seems to be, for the most part, cognitively neutral in most people who have bipolar disorder.
Wow.
Yeah.
Good to hear.
Yeah. It's really interesting because lamotrigine, is derived from an anti-malarial drug called pyrimethamine. And lamotrigine is a drug that I would use along with lithium added to some of those atypicals we discussed earlier. And I don't need to worry about further cognitive decline or weight gain or sexual dysfunction, which we can see with other psychotropic medicine.
The next question is, using your screening for bipolar differentiation, how does substance use potentially give a false positive?
Oh, yeah, absolutely. And again, these questions are just wonderful. And first of all, I think screening tools are so useful because it can save us time. If the patient screens negative on a screening tool, good chance they don't have bipolar disorder. You can truncate and shorten your assessment, frankly, because they probably don't have it. If they screen positive, you have to really roll your sleeves up and take a good history. And that's where you really want to dig deeper. The rapid mood screener I described, it has good sensitivity and has good negative predictive value. If you screen negative, you don't have bipolar disorder. Likely, if you screen positive, you in fact need to really dig down deep to find out if the patient has bipolar. Where alcohol, in fact, can sometimes result in a screen positive for many people with bipolar disorder is that alcohol itself can be associated with negative mood states like irritability and anxiety and agitation. It can also result in insomnia. It can result in mood symptoms like depression, anhedonia. I can keep going. And this masquerade as bipolarity, creating a false positive. Now, we all know that alcohol and drugs are very common in people with bipolar disorder. So these are not mutually exclusive. And if a patient has bipolar disorder and abused drugs and alcohol, I think that the screening tool can still serve a very good purpose. But I'm cognizant of the fact that the drugs and alcohol can mimic, at least they can induce symptoms that mimic core features of bipolarity. But I certainly screen all patients with bipolar disorder with or without drug and alcohol misuse, and I would address a screen positive exactly as I would in someone with bipolar disorder screening positive who does not have drug or alcohol misuse.
Wow, that's great answer. Thank you for that. Our final question is, what is considered a quote unquote mood stabilizer in 2022?
Oh, wow. That's such a great question. And, Sabrina, it inspires me to actually maybe write a paper on that because this is so interesting. We had this Yeah, I got to. It's just a great question. I thank my colleague for that. I should do that. I'm going to do that because we use language. Words matter. Words matter. And mood stabilizer has been around for decades, and that sort of usually meant lithium and valproate. And then you say, okay, well, what's lithium and valproate? It's a mood stabilizer. What's a mood stabilizer? Well, it's lithium valproate. But that's not really. That's circular. And so, what is it? And I don't think we really had a definition. The FDA's never approved a mood stabilizer. They don't use that language. So I think today in 2022, as we've thought about this more, we've marinated it more in our minds. I think mood stabilization, to me, this is just me speaking off the cuff here. For me, what it means is coherence. Now, what does that mean? Well, what I mean by that is that not only do they have mood symptoms in remission, but they also have their sleep, their circadian rhythm normalized. They also, in fact, no longer have affective instability. A lot of patients are perfectly in remission, but their mood's still unstable. And interpersonally, they're very reactive and short with people and or anxious with people. And so that type of affective reactivity. Now, I'm asking a lot. I'm asking the world of something to be a mood stabilizer. This is a lot to ask for. But what I would like to see is coherence. That is they no longer have that maladaptive mood reactivity. They no longer have depression or hypomania or mania, and they also have a normalized circadian rhythm. That's a heck of a lot to ask for, but I'm going to ask for the world. That's my definition of mood stabilizer. But in the interim, I'm happy with a medication that can keep patients in remission, both mania and depression, regardless of what that intervention is. To me, that's what a mood stabilizer will be for today.
Excellent. Thank you so much.
Thanks, Sabrina.
I look forward to reading that paper.
Yeah, absolutely. Certainly, it's something for me to think about. It's a great question. And I want to look, this has been wonderful as always, Sabrina, to do this with you. And I want to thank all of our colleagues for submitting the questions. And I hope that they're helpful clinically.
Yes, absolutely. Thank you so much, Dr. McIntyre, for joining us.
Wonderful to be with you, Sabrina. Just wonderful. Thank you.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.